Okay, I think we're ready to get started. First, I'd like to introduce Dr. Lynne Dunphy. Thanks so much.
Hello, and thank you all so much for joining us for this educational seminar, Diagnosing on the Spot and a Guide to Solitary Lesions. I'd like to share a little bit more about us. My name is Dr. Lynne Dunphy. I have been in the nursing profession for more than 40 years and am Professor Emerita at Christine E. Lynn College of Nursing in Boca Raton, Florida. Many of you may know me from my textbook, Primary Care, The Art and Science of Advanced Practice Nursing. But I'm here tonight representing Visual Diagnosis, and it's my great pleasure to be able to introduce our presenter today, Dr. Azeen Sadeghian. And Dr. Sadeghian is a board-certified dermatologist in Baton Rouge, I'm thinking Boca Raton, Baton Rouge, Louisiana. She earned her medical degree at Louisiana State University School of Medicine in New Orleans, and then completed a clinical research fellowship and dermatology residency at Tulane Health Science Center in New Orleans, Louisiana. Dr. Sadeghian's expertise in diagnosing and treating a wide range of conditions affecting the skin, hair, and nails. She is passionate about atopic dermatitis and digital educational resources, including visual diagnosis. Professionally, she is active in the Louisiana State Medical Society, sits on the advisory board for the American Academy of Dermatology, and serves as the editorial committee chair for the Women's Dermatologic Society. She's currently a volunteer adjunct assistant professor at Tulane Health Science Center. We are thrilled to team up today to present this educational webinar on solitary lesions for the primary care audience. Following the educational presentation, we will test your skills with a fun quiz called Kahoot. If you have not downloaded that app, do so now so you are ready to participate. Feel free to ask questions along the way. Your microphones are muted, but you can put a question in the Q&A section. We plan to have additional webinars in the future aimed at the NP audience. So please don't forget to fill out the survey at the end of today's topic on topics for future webinars that we can plan for you, both dermatologic and broader primary care. So without further ado, Azeen, take it away.
Hi everyone, thank you for having me, and thank you to VisualDx for having me, and we appreciate Almirall sponsoring this webinar. And I really want to say thank you to everyone who registered and was planning on attending last week. I appreciate you being very flexible. We did have a hurricane come through. Fortunately, our city was relatively spared, but other areas of Louisiana were hit hard, particularly at the Lake Charles area. So I'm very grateful that you guys are still attending, even though we had to postpone this week. So I just want to share something about me. I love skin. So I definitely went into the right field, and I'm very excited to give you this talk. And my understanding is most of you guys are primary care practitioners. And so we really put this presentation geared towards general practicing practitioners. And so for those of you who are specialists, welcome. I still hope you take away a lot from this. And for those of you who are seasoned, you know, in dermatology, I still hope you can learn something from this. And you might just find that this is a refreshing review. So this lecture is going to be a whirlwind. I'll tell you that right now, because it's a lot to fit into a 1 hour talk. But we're going to try, okay? And so it's going to be a lot, buckle up. We can't cover all solitary lesions, but we really try to think of the solitary lesions you're likely going to see. They're mimickers and the ones you really can't miss. So pretty much I'll be doing 2 hours of talking. In 1 hour, I took a shot of espresso an hour ago and I ate a cupcake, so I'm ready to go. So, okay, you need to know how to do a skin exam. I can't cover that all in this talk and get to everything else. I really recommend LearnDerm. It's an online module on VisualDx's website. And these are just kind of some slides that will show you what the module looks like. And so it's so helpful. I really recommend you look at this, especially before you start learning about skin lesions. So and morphology review. This is also taught on Learn Derm. Now, I know this really could be a separate lecture, how to do a skin exam and how to talk about morphology. We would love your feedback. If this is something you're interested in, please let us know. We can definitely consider this in the future. Just drop us a line. But as of now, I'm going to defer to you to Learn Derm, just so you can take your time and learn this, and we can focus on solitary lesions. Okay, how do you approach somebody who comes in with a spot? Well, they're going to come in and they're going to be like, hey, I've got this spot. You really need to know the symptoms, okay? Like, does the spot itch, or anything like that? Does it bleed? Does it have any symptoms? Is it asymptomatic? That is equally as important. Where is it? Is it on UV exposed skin? Is it in a private area? Is it on a nail bed? Is it on the scalp? Like, all of these things are very important. Onset, how long has it been there? I usually like to think of this. So if there's been a spot there since somebody has been born and they're now in their 60s and that spot hasn't significantly changed, it's probably okay. I'm just saying that as a generality, but if it hasn't tried to hurt them in 60 years and it hasn't been changing, it's likely a friendly spot. So stability, that kind of leads us into stability. You can gauge that from onset. Associated symptoms, another important thing is skin type. That's your Fitzpatrick skin types. That's like your very fair to very dark skin types. And why is that important? Because lighter skin types are more predisposed to UV damage because they don't have that melanin to protect their skin, and that can give you some clues. And then certain types of locations of melanomas, we have to be more cautious about in darker skin types. There are a lot of tips and tricks to examining the skin too, and I encourage you to do this for solitary lesions. You want to feel the spot. It's not just by sight, you want to feel the spot. And some tricks to also help are like you can stretch the skin. You can see if it's the skin lesion stretches with the rest of the skin. You can shine a light, especially at an angle, and you can kind of see the skin texture differences. Is it disrupting the normal skin marking lines? That's a really nice trick. And then you can buff it with gauze, particularly if you think it's something that is scaly and the skin can erode easily. So, okay, before we get started, I want to introduce you to my dog Buck. I promise there's a reason why I'm showing you this slide. Only one of these dogs is Buck, okay? But they all look the same. So meet my dog Buck. He's a rescue. He's on the left. When we got him, we thought he was a spaniel mix. The cute floppy ears, he had to be a spaniel, right? But only one of these pictures is him, the left. The top right is a dog breed called Boykin Spaniel. And we had an anchoring bias because of the floppy ears. We thought he was a spaniel. Well, that got debunked because Boykin Spaniels are actually pretty small. Then we thought, well, he's big. What about a German long hair pointer? And look at that dog. It looks just like Buck. But he's neither of these. That is an example of premature closure and availability bias. So we're basically, we're saying he's this breed because we were anchored on how it looked. And then also, those were the only breeds we knew about. So I use this to illustrate a point. You don't want to just learn to learn. You also need to learn how you're going to make a mistake and try to prevent that. And by learning that you can be biased, especially by sight and by what you know, will help you prevent making a mistake that could potentially harm a patient. So I like to do something because of this. These are 3 different pictures of 3 different dogs. I want to show you pictures like this later on in the presentation so you can see skin lesions that look similar to each other and kind of see the subtle little differences, and we'll talk about them. And obviously you're not going to be like this master whiz by the end of the talk, but you should feel a little bit more confident and able to okay, well, let me make sure it's not this. Let me make sure it's not this. And I hope that will provide some help. I want to start off with a case. This is actually a personal story. Whenever I had a patient who came to my clinic. He had intellectual disability and he was under the care of a legal guardian and a caregiver. The caregiver actually brought him to his appointment. He came in with the chief complaint of a stub toe. And more specifically, it was a toe wound. He traumatized the right hallux toe. He wasn't sure of when, and he felt that the shoes were preventing the wound from healing, and so did the caregiver. They also felt that the shoes were preventing him from healing. We thought this was an acute trauma, and so we began treating him with topical antibiotics. Okay, and I'm going to show you an image. Now, this is not my patient's exact picture. This is just a very similar, and clinically, it looked just like this. He came back a month later, no improvement. So we cultured it. It was growing staph. And so we treated it more aggressively with oral and topical antibiotics and wound care. And I'm really kind of getting anchored and stuck on the history, right? And there was no improvement. And fortunately, I worked with a colleague who was a Mohs surgeon, and he's like, you know, I've seen something like this. I think you should biopsy it. We did. No squamous cell carcinoma of the nail bed on the toe, not a sun-exposed area. And this is kind of to show you that everybody needs to reconsider their diagnosis if it's not responding as it should. And it never hurts to get a second set of eyes on things. And any non-acute lesion that is not healing, even if it looks like a wound, and if there's a history of trauma, you want to consider, am I missing something else? So we're all human. Never be afraid to reconsider your diagnosis or ask for an unbiased second opinion. Okay, these are some warning medical conditions. What I mean is, if you hear this in the history or you see it in the chart, you need to be more cautious. Immunosuppression, that could be if the doctor caused immunosuppression or if the patient is immunocompromised through any means. It could be through medication, organ transplantation, or even virus such as HIV. Any genetic or cancer disorders, that can predispose you to skin cancers. Scarring skin disorders can predispose the skin to skin cancers. And history of radiation treatment to affected site. Those are some risk factors. And there are many more, but these are the ones I feel like that aren't really talked about. You know about the UV exposure, tanning beds, things of that nature, but these are some other ones as well. Okay, other at-risk populations or UV exposure. People get blistering sunburns. That's not good. Occupational UV exposure, your welders and your pilots, okay? So that's why it's important to know their job. Tanning bed use, it doesn't matter if it was remote use. If it's current, you definitely need to tell them to stop tanning, but even if it was in the past, they still need to get routine skin checks. Okay, benign or not benign. Here are some clues to raise your suspicion based on history. Is it symptomatic? That's usually a clue that you need to take a look at it. Changing, you need to look at it. Growing, you definitely need to look at it. Bleeding, not good. Not healing, that's not good. Not responding to appropriate treatment, look at it, okay? And consider, like, is this not benign? Because there's a chance it's not. This is going to be the overview of the skin lesions that we selected for today's talk. And I'm going to cluster them based off of these boxes. Now, this is kind of categorizing based off of looks, like your brown dogs, your golden dogs, etc. So the yellow square on the right of your screen is actually the bad stuff. So that's why I highlighted it. Keep in mind that these can actually go into multiple boxes and categories. So this is just more, an overview. Okay, so we're going to start with the browns. And now when I say browns or any other category, like I said, it's not a rule. I'm oversimplifying this right now, because right now, for the sake of a first pass learning, like just kind of showing it to you for the first time, let's think of just kind of like common is common, right? Freckles are brown, think of it like that. But just know that that's not how these present all the time. So this is just first pass learning. Okay. And we're going to learn the variations later, and then you'll continue to learn the variations whenever you're practicing. Okay, a lentigo. A lentigo simplex is common, benign, hyperpigmented macula, can occur anywhere on the body, happens early in life, not associated with sun exposure, so it can happen under the shirt, asymptomatic, well circumscribed, symmetric, homogeneous, brown macules less than 5 millimeters in size. The edge of the macule can be jagged or smooth, and it's typically darker than a freckle and does not darken or increase with sun exposure. And sometimes they can evolve into junctional nevi or a mole. We're going to show you that later. Solar lentigo are known as age spots, liver spots. Those are sun-related, UV exposure-related, and usually occur in older patients. And they can be 2 millimeter, 2 centimeters in size, smooth or irregular, and they can vary in color from light brown to dark. And the clue is that they're usually on UV exposed skin. Now, ephelides are freckles. Those are the small uniform speckly dots that you see on, the freckly cheeks of a child. Those are freckles. So that's ephelides, something else. Okay, so here are some examples of a lentigo simplex is on the top left. This is a labial lentigo on the top right, on the lip, and then solar lentiginese on the bottom picture. This is probably someone who's gotten frequent sun exposure or sunburns, to develop this. Okay, nevi. Nevus is a singular term for mole, nevi is a plural. Common acquired nevi or moles, they come in 3 flavors, junctional, dermal, and compound, and that just shows you where they are in the skin. They're benign, they occur in all skin types, doesn't matter the skin color. They arise during childhood, adolescence, and early adulthood. So anytime especially somebody who's in their middle adulthood to later tells you I have a new mole, you need to look at it and possibly monitor it. They're well circumscribed, can be flesh colored, pink, brown, or even blue. And so what I like to say is benign nevi respect the skin. So, and patients tend to make a typical flavor of nevi, meaning they make a certain type of mole. It might be that their moles are all speckled or, something, but they tend to make something where it looks like they made all their moles. So if you see one that doesn't fit, that doesn't match their other moles, I typically flag it and I monitor it or consider biopsy. So for example, let's say a patient has a bunch of brown moles and then they make one new mole, but it's pink. That's not right. So I would look at that and monitor it and possibly biopsy it. So other variants we'll talk about in the next slide, congenital nevi and dysplastic nevi. Congenital nevus, it's usually seen near birth. If not, it arises when you're still a baby and or early childhood, and it doesn't have to be there at birth, but it typically happens very young in life. And they have a very unique appearance. They can be alarming if you see one in an adult and they don't tell you that it's been there since they were a little kid and it hasn't really changed. So ask that. To the top right is a blue nevus. And then an atypical nevi we have at the bottom right. These are clinically irregular. Now for it to be called dysplastic, you have to biopsy it and it has to show dysplasia underneath the biopsy. So it's atypical, clinically, dysplastic under the microscope, and that comes in 3 types, mild, moderate, and severe. That needs tailored monitoring and treatment, and that honestly could be a talk of its own because it's kind of a tough area in dermatology where, consensus kind of varies on how to treat the milds and moderates. Everyone kind of agrees that severe you need to cut out or, be a little more aggressive with those. Okay, so warty, that's our next category. Seborrheic keratoses, classic warty, common, benign. These are the barnacles that we talk about. They're waxy, warty, stuck on, occur in adulthood, usually later in adulthood. They can affect any skin type. They have a unique feel to them. So if you see one, feel it next time. It's almost like you can kind of dig under it and pull it off. You can't, but it almost feels that way. Because of that, kind of, sometimes they get caught on clothing and things like that, and they can actually become irritated. And when that happens, it can become symptomatic. When they become irritated, unfortunately, sometimes it can look like skin cancer, and it can be really hard to tell the difference. So we're just going to talk about the classic version. Okay, Verruca. That's classic wart. So warty, wart. There you go. Verruca vulgaris. It's caused by HPV. Solitary. It can be solitary or multiple. Verruca is hyperkeratotic. You can see black or red dots, which are thrombosed little vessels, and that's characteristic of warts. They technically are benign, but I will say this, if they don't resolve in a timely manner, I do think you need to keep an eye on them. Sometimes, rarely, you might have, it might actually be a skin cancer. And they can look similar. But a common wart technically is benign. Treatments indicate if somebody's immunocompromised, it's a sensitive location, or if there's risk of auto-inoculation. And I say if it's not resolving, especially if it's lasting over a year, consider sampling it. Verruca planar flat warts, they tend to be multiple, and they're spread by auto-inoculation. For example, like shaving is a common way to spread it. They can be slightly elevated, flat top. The fact that they come in multiple really helps you diagnose it. And I'm sure it's possible to just have one, but for the most part, what I've seen has always been multiple. And so anyway, they can range in color from pink skin colored or hyperpigmented, and they usually have a unique texture. So this is where you can kind of see that it's affecting the skin markings, and that's why looking at texture is so important. Next, we're going to talk about red. Okay, Angiomas, classic red. Cherry angiomas or cherry hemangiomas is another name. They're the most common acquired benign vascular proliferation. They're thin-walled, dilated capillaries, happen in adulthood. You tend to get more as you get older, and they are asymptomatic benign, but occasionally they can become irritated or bleed. They can also increase with pregnancy as well. Pyogenic granulomas. These are known as lobular capillary hemangiomas is a more proper term. They rapidly grow over the matter of weeks, and they're benign vascular proliferations of the skin or mucous membranes, meaning it can happen on the lip or anywhere else. So majority are without cause, but they can be associated with injury or hormones such as pregnancy. And they like the trunk, head, neck, hands and fingers, gingiva, and the lips. They are painless, but they can ulcerate and bleed easily. And they're more common in young adults and children, but they technically can occur at any age. They can be glistening. They're friable, meaning that they sometimes it's almost like it's trying to come apart. But for the most part, they look very classic. There's a Colorado scale around it, and the base looks very pathognomonic, and they usually occur just one. And so I will say, if you see one on a pregnant woman, it's on the oral mucosa that tends to go together. So, okay, bumps or lumps. Cyst. I think everyone knows what a cyst is, and there are multiple types. They depend on the cell wall or lining. We're going to talk about epidermal inclusion cyst or epidermoid cyst. Those are kind of what we think about. Cyst wall is made of squamous epithelium, think of skin, that's squamous epithelium, and contents are macerated keratin, which is skin protein, and lipid-rich debris. So it's basically like skin grotto in there. And they're fairly common. They occur on the face, trunk, extremities, even the genitals, male scrotum, it can happen there. And they're more common in men. They're firm, skin colored. They may or may not have a punctum, and they may or may not have a history of malodorous material that can be expressed. Now, if somebody tells you it's ruptured before, that kind of gives you a clue, like, okay, this is a cyst. So here we have 3 pictures. On the left, you can see that one's inflamed. And so inflammation doesn't always mean infection, but these can sometimes become infected, but more often than not, it's just a rupture causing severe inflammation. Antibiotics sometimes decrease the inflammation. Usually infection, you'll have more clear symptoms other than just redness, erythema, and tenderness. You might have like even worse odor, but it's kind of like an overlap. It's sometimes hard to tell clinically. So, okay, digital mucous cyst is a different kind of cyst. This is a myxoid cyst. It most commonly occurs on the DIP digit. So, right, that's your DIP digit, and it can be skin-colored, translucent papule. It can almost look like it has clear fluid in it, and sometimes you get this nice longitudinal groove in the nail, which you can see on the right side. And so these tend to be solitary, rounded, and translucent, meaning that it almost seems like light can pass through it. The fluid inside is almost gelatinous or viscous. You may hear a patient who says they try to pop it and clear stuff, gel came out. I don't recommend patients popping it because you can actually get an infection in the joint that way. And so these cysts tend to be actually associated with osteoarthritis, and larger cysts can become painful. If it's not painful, there's really no need to necessarily remove it unless if there's other indications. So, okay, lipomas or benign fat tumors, usually asymptomatic. They're soft, squishy, mobile, subcutaneous. There's no overlying skin changes. They can occur anywhere. They like fatty sites. They can be single or multiple. These are actually kind of fun. Angiolipomas are a little different. They can be tender. It's basically a lipoma that has some extra blood vessels in it. Those can be tender, but plain lipomas tend to be asymptomatic. It's a warning sign if they grow rapidly or become fixed. In that case, you may want to consider sampling it or removing it if it's possible. Okay, we're going to talk about skin cancers and precancerous lesions. So kind of overall categories, scaly and bad. Actinic keratoses. Not technically cancer, but considered precancerous and a precursor to squamous cell carcinoma. Not all of them progress to cancer, though. We just don't know which ones are going to progress. And so we typically, and it's an indication that that patient is at risk for developing skin cancer. So we tend to monitor these patients. If you, so the risk factors are related to the fact that their skin's already been damaged by the sun to create a lesion like this. Happens in sun-exposed areas, usually older patients. They may be symptomatic. Sometimes patients say they itch, or they might occasionally bleed. Erythematous scaling papules, and they tend to be, you can't get one, but sometimes you'll see signs of other, like little smaller actinic keratoses nearby, or significant sun damage. There's lots of treatments. Cryodestruction is one where we freeze it, but if somebody's covered in the actinic keratoses, a lot of times we consider something called field treatment, where we treat all of this involved skin. And I recommend skin checks and photoprotection and monitoring these patients. Oh, and if it fails to resolve with treatment, you do need to sample it and biopsy it. Squamous cell carcinoma is cancer. It's the second most common form of skin cancer. It can occur anywhere. Risk factors include, they're multiple: UV exposure, photo exposure radiation, immunosuppression, HPV, chemical exposure, fair skin, chronic wounds, scars. I'm even talking about like chronic draining fistulas, or if somebody has like a long-standing lichen sclerosis or discoid lupus scarring, any long-standing scar technically that could be at risk. There is a potential for invasion and metastasis. There are varying types. Location portends whether or not it's a higher risk of recurrence. Head and neck is not a good site for squamous cell. You want to monitor patients, check lymph nodes, and do routine skin checks. The classic finding for squamous cell is erythematous scaling plaque. Other presentations include nodules, ulcers, and various other findings. I definitely recommend you look at VisualDx and look at all the pictures of squamous cell because it's quite impressive. You can get erosions, ulcers, bleeding, symptoms such as like tenderness, not healing, recurrence, a lesion in a spot, like it heals and it comes back, heals and it comes back. Duration is another thing that these are all clues that you should biopsy. The best test is biopsy. I always biopsy anything I think is cancer. And then if it comes back as squamous cell, surgery is usually your preferred form of treatment. Once you have a skin cancer, you basically need a dermatologist for the rest of your life to do routine skin checks. So, if your skin was damaged enough to form one in one place, that means other areas were damaged too, or you're at risk for your other risk factors. Okay, so pink and bad. Basal cell is what comes to mind, although technically multiple things can be pink and bad. So we will cover that, but first thing I think of with pink and bad is basal cell. They tend to be pink, although they can be pigmented too. It's the most common form of skin cancer. There are various subtypes. They rarely metastasize, blundering on my word here, metastasize, but they can be very locally destructive. They just kind of keep growing if left untreated. Risk factors include ultraviolet radiation and fair skin types. Most common presentation is your pink perlate papular plaque with telangiectasias. They can be pigmented or ulcerated. So you see these three pictures here. And I hope you guys are looking at the pictures while I'm talking. You don't need to read the slides. I want you to look at the pictures. So you see how it has that rolled border and they're pearly, you don't see significant scale, the pearly aspect, in which you can see when you shine the light on it. That's the important thing. Okay, black and bad. Melanoma, okay, that's the first thing you should think of if you ever see a black skin lesion. It's a very aggressive tumor of melanocytes, which are pigment cells. It can spread easily. It can occur anywhere. It can occur in the genital area, it can occur on the foot, and it can occur on any race. Nobody's spared from melanoma. There's multiple subtypes. Risk factors include a personal or family medical history of melanoma, history of severe or blistering sunburns, a changing mole, a giant congenital nevus, which is greater than 20 centimeters. Age is a risk factor, having a lighter skin type, and multiple atypical nevi or tanning bed use. The ABCDEs are going to clue you in to melanoma. We're going to talk about that later. The ugly duckling sign, what I was kind of alluding to earlier, if you have a mole that doesn't match the patient's other moles, that should clue you in. That's your ugly duckling. If you have a new symptomatic or changing mole, that should clue you in too. We don't do a normal shave biopsy on these. We tend to cut them out if we think it's melanoma because the pathologist needs to know the depth. And so we do an excisional biopsy, and then to treat it, excision is the gold standard. Lymph node exam and skin checks are all dependent on each patient, but you have to check the patient's lymph nodes in terms of clinically. Whether or not they need scans is a different subject depending on the depth of the melanoma, but these patients will need skin checks for the rest of their lives. And there's certain indications for imaging and lymph node biopsy. So Bob Marley got melanoma on the bottom of his foot, so anybody can get it. And the depth is very important prognostically, and the deeper it is, the worse the prognosis. And so we can see that melanoma here. We see it in the nail bed. We see it on the skin. You can see it doesn't look normal. It's not round, brown, even. It's asymmetric, irregular borders, multiple colors, diameter larger than a pencil eraser or 6 millimeters. And they grow, they evolve. Those are your ABCDEs. Okay, this is something that's black, but it's okay, it's not cancer. It's called a Talon noir. It's the French word for black heel, asymptomatic discoloration of acral skin. It's due to bleeding into the skin. It could be on one or both sides. If it's both sides, that's so reassuring. A lot of times these patients will tell you they run, or maybe they had like some shear trauma to their foot. You can pare it down with 15 blade, and it should, you can see that like the top, when you remove the top layers of skin, it's no longer there. So that's reassuring. It has a very unique characteristic look and a unique location. And so if you see something on the heel, obviously if you're not sure, you never want to miss melanoma. No one's going to fault you for missing this, but they are going to fault you for missing melanoma. So, okay, we're going to go over pictures, and we're going to go over them pretty quickly, okay? Let's pause for a second and reflect. I know we learned a lot, but we're going to try to do a second pass now and look at a bunch of images. And I want to ask you a challenge. This is to challenge you, though. Do you have a diagnostic process that allows you to think of a differential? If not, I really want you to think about that tonight. Think about Buck, my dog. Those three dogs all look like him, but they were 3 different breeds. And so skin cancer can be like that too. Skin lesions can be like that. And you don't want to miss a skin cancer and make a mistake because you don't have a process that allows you to think of a differential, and you don't have a process to guard yourself. Okay. Take a sip of water. If you're at home, have a snack. Okay, we're about to dive in. Okay, so we're going to go through the scaly. Okay, this is heme-crusted erythematous scaly plaque on the scalp. Look at all that sun damage. It's irregular. This is a squamous cell carcinoma. Next, erythematous scaly flat papule. This is small. If I had a little ruler, it would probably be less than 5 millimeters, definitely less than a centimeter. You would want to feel this because sometimes just looking at it doesn't seem impressive. It would be palpable but not indurated, meaning you'll feel that kind of scale, but it shouldn't feel thick. It's small, tiny, really. But you see there's a background of some photo damage. You see that dyspigment, kind of like the little freckles all in the background. Well, those are actually solar lenigos, probably like little baby solar lenigos, if I had to guess. And so, but if you would treat this, if it doesn't respond to treatment, you would want to reconsider your differential and consider biopsy. Okay, this is a heme-crusted, or when I say heme-crusted, like there's kind of that dried blood crust, erythematous scaling plaque. And there's some scale to here, but this is really an S-scar or a scab, really. And there are some erosions, meaning that the top skin layers have kind of been eroded in some areas, and you can almost see like a little bit of the moist areas underneath the top layer of skin. And there's infiltration at the border. Like that is a hard border to really draw your pin around. It almost looks like it's trying to sneak in underneath that layer of skin. So that's a squamous cell carcinoma. Okay, this flat warts. Multiple, easy. You can see that there's slight scale. The fact that there's multiple and they're kind of flat and uniform looking, this kind of clues you in that this is benign. Fortunately, when it's multiple, you tend to see that there's like a little bit of a spread. Sometimes you see streaks are coalescing. You can tell that there's some pattern of distribution. Okay, this is a tough one. This I actually may get stuck on. This is a seborrheic keratosis, and I want to show you the clue. This is very waxy and warty appearing and scaly, but you can see that pale area beneath it. That's where the rest of the seborrheic keratosis was. I bet you part of it had fallen off or got caught on something. So you can kind of see that, you know, that's a subtle clue. But when in doubt, it's okay to test these. I've biopsied seborrheic keratoses before because they didn't look like the classic seborrheic keratosis. These can throw you off, but they're very common, very benign. This is a wart, okay? It's a Verruca vulgaris. You see that papillomatous surface. You see like all those little projections kind of coming at you. Ooh, yeah, that wart, that HPV virus, so virusy. Anyway, that is classic wart. So here is multiple warts. Okay, you kind of see those little projections or verrucas, and you can see that since there's multiple, you tend to think of like an infectious etiology. This is a wart on the nose. You see those little projections, and you see the thrombose little blood vessels, those black dots. You see those black dots? That is what we're talking about the red or black dots. Those are thrombose capillaries. Okay, this looks like a wart, but it's not. It's warty. It's a seborrheic keratosis. It's crumbly. It's waxy. It's like a barnacle. See how you can almost, like, if you feel it, it almost feels like you can kind of peel it off. It lacks the striking papillomatous appearance like the other warts we saw. You don't see any thrombose vessels, but it does look like somebody took a barnacle and stuck it on the patient, like wax applied to the skin. Here's another one. They can be dark. Seborrheic keratoses come in a bunch of different colors. They can be dark, they can be gray, you know, but look at the border. I can almost like outline that whole entire border and lift it up. It's not going to feel indurated into the depth of the skin. It's going to be sitting on the top layer of skin. And so any cancer this size, you would be able to tell it's like deeper in the skin. Okay, now this is not what we just saw. This is a verrucous carcinoma, a wart-like cancer. It's a subtype of squamous cell carcinoma. So this is a squamous cell carcinoma. Its subtype is verrucous carcinoma. So meaning it looks warty, but look, it's like infiltrating into the skin. There are certain areas of the border where you can't just outline around it, and it looks like it's changing the surrounding texture of the skin as well. It's indurated. It's infiltrating the skin. If you lift this up, it's going to pull the skin up. If you move this skin lesion around, it's going to be fixed to the skin and the deeper structures of the skin. Okay, this is a cutaneous horn, which is it's technically, this cutaneous horn is called a keratoacanthoma, which is a type of squamous cell carcinoma. And they have a very characteristic look. On the left is like the more kind of classic look. On the right, you see, I'm not talking about the patient's left, I'm talking about your left. And then on your right, you see the horn. And so the concern with horns is that they can have a cancer or precancer beneath them. Although sometimes they just have a wart, you don't want to miss a cancer. So a lot of times we do biopsy cutaneous horns. Okay, bleeding. This is an ulcerative basal cell. Okay, but I showed you pink pearly papule for basal cell. How is it bleeding? This is a variation of it. When things are like this, you have to consider cancer. But you see how that border is pink pearly, okay? And it's irregular. So that's your clue that it's basal cell. This is also a basal cell. It's kind of hard to see, but it has a pink pearly border at the top aspect at the 11 o'clock to 12 o'clock. It does not look like a pyogenic granuloma because it has an irregular border and it has multiple lobules and it has heme crust and a scab on it. This is cancer. Now this is a pyogenic granuloma or lobulary capillary hemangioma. It is clean, round. It has it's proud flesh. It's just round. Okay, so we'll go to the next one. Pinks and red. Now this is a basal cell, classic basal cell, pink pearly. It has large arborizing telangiectasias, or that blood vessel that you see. The skin texture is different, and you see how it's taut, and it's on sun-damaged skin. That's a clue. Basal cell, classic pearly pink border, telangiectasia, and you notice central erosion. Okay, that means the skin's not able to keep itself held together there. That's usually not a good sign. Okay, this is another pink bump, or flesh color bump rather. It's a nevus. It's a dermal nevi. They can be beige. They can sometimes be pink. But this is round, smooth. It looks happy. The surrounding skin looks happy too and healthy. down. Okay, next. This is a tricky one. This is a cherry hemangioma, but it's on sun-damaged skin. But see how it's uniform? It's violaceous, it's red, it's symmetrical. The surrounding skin is unaffected, and there's no infiltration. Here are multiple angiomas. This makes it easy when you see multiple. If you look long enough at your skin, you're going to find one. So you have a homework assignment. You could do that later. This is something called a halo nevus. This is a mole surrounded by a depigmented or white circle around it. If it's an adult, you need to do a skin check on the whole body, because why this happens is because the body's attacking the pigment cells in the mole. So why is it doing that? In an adult, you need to make sure they don't have melanoma somewhere else. In teenagers or young children, this can be a benign, but I still recommend monitoring the spot and monitoring them. In an adult, sometimes we'll do it. I mean, not sometimes. We do a total body skin check to make sure there's not melanoma, and we'll often biopsy the halo nevus as well. Okay, this is going to throw you guys for a loop. This is amelanotic melanoma, meaning melanoma that did not make any color. It's pink. Well, I said earlier melanoma was black. Well, that I was just teaching you a generality. This is a pink melanoma. But you know this is not normal. This is not a normal healthy bump. You see there's an erosion at the 1 to 3 o'clock. There's an infiltrative border. It's not symmetric. It's on bare skin. You know, these are all clues that you need to biopsy it. And this is the one that we kind of lose sleep over as dermatologists. This is a linigo, okay? You know, it's a homogeneous type of brown. It looks very, I mean, there's no texture changes. It's very happy. Labial linigo, more common on the lower lip. This is stable from the history. It's not growing. Multiple lentigines in a child, you know, numerous uniform brown macules over the face. If it's uncommonly associated with, if you have a significant amount, you want to think of syndromes, but that's beyond the scope of this talk. But usually these are fairly common, and as long as they're not extensive or atypical in distribution. But if the patient has other medical comorbidities, such as like EKG issues, ocular findings, or freckles that are more extensive than what you would expect, then you know you definitely want to make sure you're broadening your differential to include some syndromes. Okay, melanoma. This is lentigo maligna melanoma, which is a melanoma that looks like a giant lentigo. It's not a lentigo though, it's cancer. And if you see how this is not homogeneous brown, this is very large, irregular, and these can be very tricky. These need to be biopsied, and fortunately, these tend to be just combined to the top layer of the skin, but if you don't take care of it, they can invade. Here's another example of lentigo maligna or melanoma that's melanoma. But you can see that this is irregular, multiple colors, irregular borders. This is flat out melanoma, okay? It has a race component, it has areas, I mean, you can't even draw a pin around this. It looks like part of it's missing, like somebody erased part of it. Irregular, asymmetric, it basically breaks all the ABCDs. Melanoma, this one even has scale and textural changes. Melanoma, okay, irregular border. This one, it's hard to see multiple colors, but this is definitely at least breaking most of the ABCDEs, and it doesn't have a symmetric shape by any means. This is melanoma. Melanoma, it's black. I mean, you can't even draw a line around it. This is melanoma. Can't draw a line around it. It's huge, it's large, it's infiltrative. Talon noir. You see how Talon noir, it looks different than melanoma, but when in doubt, pare it down, meaning get a 15 blade and remove that top layer of skin. And you know, here's an example that they're trying to do, but you can tell that this is blood in the skin. Okay, this is a mole, a nevus. This is a blue nevus. That means the mole was underneath the top layer of skin, so the pigment looks blue. This is a compound nevus, okay, and that's a mole. It's a little bit of a deeper mole. Okay, now this is a pigmented basal cell carcinoma. This is irregular, okay, it doesn't look like that angioma that we saw, that purple angioma that we saw. It doesn't look like a mole. It has a pearly border, even though it's violaceous blue, it has a pearly border, and it has large blood vessels, and it's on sun-damaged skin. Okay, now we're getting to lumps and bumps. Whew, this is the easy part. Okay, this is a lipoma. You would have to feel it to know, but if I told you this is soft and squishy, that would have made it easier. This is a cyst. Okay, you can see it has that yellow tinge to it. This is a cyst. Another cyst. This one's a little easier because of the skin discoloration that you see. Now this is so easy. This has a nice punctum or opening, a dilated pore. It's like a yellow subcutaneous nodule. This is a digital mucous cyst. You can see that long ridge in the nail. Okay, so we made it through the pictures, and then I've just got a few more slides, and then I'm going to hand it over. So some warning signs: if spots are growing or changing, they're symptomatic, they're not healing, they're friable on exam, easily denuded. Like let's say you got your gauze finger and you rub over it and the skin just comes off, that's not good. Or if it's rising in a chronic scar or wound or happening on a sun damage or radiation site, then that's a warning sign that you need to consider biopsy. Midline lesions are another warning sign, but not necessarily of skin cancer, but rather that you need to consider that there could be a deeper structure, meaning if it's like perfectly midline, front or back. Okay, ABCDEs of melanoma, we touched on this, but I want to drive this home. This actually came from the AAD, American Academy of Dermatology website, so but you can find this all over the internet. A is asymmetry, B is border, having an irregular border, C is color, having multiple colors, D diameter, greater than 5 to 6 millimeters, and evolving or changing. These are things that are clues that it could be melanoma. Ulceration and bleeding should prompt biopsy. Nobody should have a bleeding mole. If it's bleeding, you want to sample it. And the ugly duckling, meaning it doesn't match any of their other moles. If you tell a patient a spot is benign, I always want you to let them know they need to contact you if the lesion changes at all or becomes symptomatic, because then you want to reevaluate it. Okay, biopsy, if you're considering malignancy or you're not sure if it's benign or if there's warning signs, biopsy. Use a dermatopathologist. It's a special pathologist who's used to looking at skin. Whenever they send you a report, don't just read the top line. You want to read underneath, because there's going to be a lot of information in that paragraph underneath. The subtype of cancer is just as important as cancer, or let's say it's benign. They might put in that paragraph, well, I think it's benign, but technically you would need a deeper biopsy to make sure it really is benign. So, you know, there's important information there. Sometimes you need to re-biopsy, and a lot of times your pathologist will let you know, or if your biopsy report came back as AK and the spot like it's not going away, you're going to consider re-biopsying it. Treatment of skin cancers, we do outpatient skin surgery. Meaning we do not put the patient under typically, and there's always exceptions, but common forms of skin cancer, we just do local anesthesia. The patient's awake, they're able to talk, we don't put them under. So you don't need to send them to plastics, send them to dermatology. There's most criteria, which you can look online, but that's for high risk cancers in areas where you need a spare skin. So like if you have a cancer on the face, that's typically a Mohs area, but there's criteria. Imaging is not usually indicated except for aggressive tumors, such as invasive melanomas, some squamous cell carcinomas when you start to feel lymph nodes, and or other cancers if you're feeling lymph nodes, and then Merkel cell. So, okay, whew, we made it through. So I applaud y'all for hanging in there, and I'm glad I took that extra shot of espresso today and ate a cupcake.
Azeen, why don't you take a sip of water or something? That was a lot to cover in such a small, such a short period of time. That was great. Lynn, I think there are a couple questions. If you want to tee those up for Azeen, that'd be great.
This was in the earlier part of the presentation, the diagnosis of what was under the eye lesions. You had a slide with it was right under eye lesion.
Oh, the lentigo or the, Oh, I'm sorry, my internet just froze.
Azeen, can you hear us?
Okay, sorry, my internet just froze. Okay.
That's okay. So you're saying it was a lentigo? That was the question.
Was it a brown macule under the eye?
Yeah, and there was one with a lot of little bumps.
Okay, the one with all the bumps was a Verruca plana flatwarts.
Okay. Okay.
And check the recording for anyone, because it'll be on the recording, obviously.
Yes.
So.
Yes, because I'm trying to go based off of memory, and I'm not even, there are a few under the eye images.
There are a lot of images.
Yes. And there's a second question. Do you have any tips other than biopsy to help distinguish BCC from amelanotic melanoma?
Oh gosh, I wish. Amelanotic melanoma is the weirdest thing ever. If it's a basal cell, you're going to biopsy it anyway. I'm not of the, there are different practice methods, but I think if you're thinking cancer, you should always biopsy it, period. The reason why, because even certain subtypes of basal cell need to be treated differently. And I think what you're getting at with the question is, well, if you think it's basal cell, wouldn't you just, EDC it or treat it there? Some doctors do that, but I would say the majority biopsy it first. Just to be on the safe side, make sure it's not a specific subtype of basal cell that can be more infiltrative. But okay, on using dermoscopy, you can tell the difference. Dermoscopy is beyond the scope of this talk, but it's a magnifying lens where you can see like the blood vessels or certain features that can be pathognomonic for basal cell. But I will say this, amelanotic melanomas, don't read the textbook. So,
Okay, there's another question. Is melanoma associated with the influence of estrogens, for example, pregnancy, exogenous intake?
Oh, that is a very hard question. And what I would like to do is to, whoever asked that question, I want to get your contact information because I'm going to have to do some digging to answer that. Estrogen affects, estrogen does increase melanin production and can drive up the risk to my knowledge. But more often than not, we just see darker moles, darker areola, the linea nigra. There are cases where people can get melanoma in pregnancy, and there are some associations with people who have certain types of breast cancer syndromes that there's a possible increased risk in some of family lineages with certain genetic defects that they might have a higher chance of melanoma. So that's a very complicated question, and I want to make sure I don't get it wrong. So just send us your email address, and I will do some more digging and get back to you on that.
And Kim, someone asked about giving their contact info.
Anna, if you just want to write it in the chat, and that way we will contact you. And then Azeen, I'm going to have you stop your share so I can share and we can get going with the Kahoot. And Azeen, thank you so much. This has been great.
Yeah,
so,
thank you.
As I share the Kahoot, I just want to kind of reiterate what will need to happen. So everyone, you can either go to kahoot.it or pull up the Kahoot on your phone or another device. It's good to do this off of 2 devices. So you'll want to put in the game pin 924420. Look, great that we're starting to get people signed up because you will see the image on the Zoom, but the Q&A will be on the other device, if that makes sense. We are giving away a $100 Amazon gift card to the winner. So I do ask if we have seasoned dermatologists on this Zoom to not participate, to allow the general practitioner to test their skills. Azeen put this together based on the on her presentation, so we thank you very much. And all the images that are in the Kahoot are from VisualDx. And Azeen, why don't you talk a little bit about VisualDx while we're just waiting for more people to sign up?
So VisualDx is a point of care reference tool. I love it for dermatology because it's really like a digital atlas that you can use at the bedside. I think it's great for studying too. I think a lot of you guys, I saw in the chat, we have students and people in training. And so I recommend, even if you're practicing or a student, when you're at home later after the Kahoot quiz, we're going to be sharing this presentation, but log into VisualDx and actually look at all the images and look at them in different skin types. Look at all the variations. There are so many variations for each spot. And Another thing about VisualDx is it's great for helping you diagnose, but it's also great for helping you know how to manage and treat. So for example, if you want to know your therapeutic ladder for how to treat a wart, how to manage melanoma, things of that nature, it'll point you in the right direction.
And it's really great for building that differential diagnosis by putting in the lesion type and starting there. You don't necessarily need to know what you have. You can start with the signs and the symptoms, which is fantastic. So we'll just give this one more minute. Again, after the Kahoot is over, Azeen will also then show why answers were the correct answers. And then as you leave the Zoom tonight, don't forget to fill out the survey, because it's really important for us to know what type of presentations will be important to you going forward. So I'm going to give it about 10 more seconds, then we're going to start. You will see an image and you will have to answer what you think that image is in 20 seconds. And we have 10 images. Okay, let's get started. Okay, last one. Okay, Valerie in third place, Cash in second place, and our first place winner is Karen. So Karen, I will be in touch with you about the gift card, and thanks everyone for participating. Azeen, thank you for putting that together, and I'm going to stop my share so that you can take it back and kind of explain quickly the 10.
Yes, I am so proud of y'all for getting all those answers. I mean, you guys did a great job, and some of those, you know, were a little tricky, and there was one that I pulled straight from the PowerPoint, so I'm glad you guys got that one. Okay, I'm going to share my screen, and let's get started. Okay, so these are seborrheic keratoses. I saw that a lot of people thought these were nevi. The difference is the texture. You can see that these are almost warty looking. They almost look waxy, and they're definitely on an older skin type. You know, to see this distribution is classic for seborrheic keratoses. And you can even see that there's one that kind of partially fell off. Let's see, the top left corner, or actually two. And so that kind of gives you a clue too. But these are almost like you can peel them off. So common things tend to be common. Seeing warts like this would be very unlikely, and like this many warts that are raised would clue you into somebody who's immunocompromised if it's in an area. Now on the hands, it's a little different. We tend to see multiple warts there, but all over a torso, it would be less likely. And you would also see thrombosed vessels in a wart, and you would also see that it's closer to the patient's skin type color, not like this is a fair skin patient with like brown, gray, stuck on waxy plaques. So moles would be very smooth, and they wouldn't appear like this. And congenital nevi do not have that waxy appearance either. Okay. This is an epidermoid cyst. A couple of clues. This would, why it's not a lipoma, you would be able to tell this clinically a lot easier, but a clue in the picture is you see that little punctum right there. And then you also see acne scars. This like to occur in acne prone areas as well. Okay, this is an actinic keratosis. You can see that there's significant sun damage on the skin. And this is on the background of sun damage. I would not call this a squamous cell carcinoma because it doesn't seem very, it doesn't seem like it's really going significantly into the skin quite yet. And so this would be considered a precancer. Okay, this is a common acquired nevus. This one's a little bit harder. Seeing, it's very important to learn what the skin lesions look like in skin of color. You can tell here that this patient, I'm trying to point to arrows to the hairs. The hair follicles are still intact. That means whatever this lesion is respecting the hair. And this skin lesion is symmetric. It is well circumscribed, and it's not irregular. It's just one color. So that makes it a nevus. Pigmented basal cell would have a pearly border. It would likely not spare the hair follicles. Cancer tends to not respect hair follicles, and so a lot of times those are the first to go or be affected. Seborrheic keratoses would have been scaly, and melanoma would have followed the ABCDE. Okay, Talon noir. This is pretty easy. You can see that the clinicians pared away some of the skin, and you see these little black dots or even red dots from the thrombosed vessels in the skin or the blood in the skin. And so that makes it kind of easy to tell, but when in doubt, no one's going to fault you for kind of digging a little bit deeper figuratively, not with the 15 blade, but if you need to take a sample, take a sample if you're not sure, but this is classic for Talon noir. This is significant for acral lentiginous melanoma, a subtype of melanoma. It has irregular borders. You see right there that in the top left, it almost looks like it's seeping into the skin. And then it has multiple colors. The arrow to the right, you can see that, the arrow to the right, it looks almost like the pigment's diffusing into the skin. And so you can see that it's just very irregular, very large. This is a pyogenic granuloma or a lobulary capillary hemangioma. I put the arrow where that perfect collarette is, and you can see that this is very round. Angiomas do not have this raw flesh where it's almost wet in appearance. This is clearly vascular lesion, so it's not basal cell or nevus. Nevus, would not appear this vascular, and basal cell would have a irregular pearly border. Okay, this one's a tricky one. It looks like a wart, but it's not a wart. This is a squamous cell carcinoma. It's one lesion, but you see how it has infiltrative borders. And so it's almost like pulling the skin. It does not, and it's almost seeping in, the borders are almost seeping into the skin, and it's infiltrative. It does not respect the surrounding skin. Although a wart would be in your differential for this, it's less likely because of how extensive this is in size and how it is disrupting the surrounding skin. So a biopsy would be warranted. This was in the presentation. You can see the significant actinic background, and this is an irregular lesion, pearly borders, large telangiectasias, and this, I think the closest thing to this is you want to make sure it's not a hemangioma, because it almost appears to be like, it could at first glance vascular, but it's not vascular. You can tell that this, when you look more closely at it, that is pigment being produced by this lesion. And hemangiomas, even when they're purple, they're going to be more dome shaped or more regular in appearance, symmetric. It's going to have an even topography of the lesion and regular borders. And a blue nevus would also be very symmetric and round and uniform without that pearly texture. This isn't a common acquired nevus, and the clue here is this spot is almost, it almost looks perfect. It's a beautiful mole, very symmetric. It has happy, healthy hair follicles in it. The mole is obviously respecting the skin, and you can draw around this so perfectly. And it has smooth borders. It's not waxy, it's not warty. And this is, if you're thinking, oh, is this a seborrheic keratoses? This is a very young patient, so that'd be unlikely. Melanoma would be irregular, and it would be more than one color. And it's not a vascular lesion. This is a very pigmented lesion. So that's pretty much it for our quiz, and we would love your feedback on it. And Kim, I'll leave the rest with you. Thank you, everybody, for your time.
Well, I just want to thank Azeen and Lynn, both of you, for helping put this together, and really for all of you that stayed with us through the having to delay it for 1 week. We really appreciate it. Please don't forget the survey at the end, and we hope to see you again in the coming weeks and months with more presentations. Lynn, anything to add?
No. It was a great presentation. I loved it.
Yeah, definitely. Thank you guys. Absolutely. Thanks, everyone. Have a nice evening.
Thanks, everyone.
Thank you, everyone.